Chiari syndrome is a disorder caused by obstruction of the hepatic venous outflow, leading to hepatic congestion, increased portal pressure, hepatomegaly, ascites, and potential liver dysfunction or failure. This obstruction can occur at the level of the hepatic veins, inferior vena cava, IVC, or right atrium, and may be due to thrombosis, external compression, or a combination of both. Chiari syndrome occurs due to obstruction of hepatic venous outflow, which can be primary, due to thrombosis, or secondary, due to external compression. Primary Chiari syndrome is mostly caused by thrombosis in the hepatic veins, or inferior vena cava, IVC. The major causes are hypercoagulable states. The causes of hypercoagulable state can be myeloproliferative disorders like polycythemia vera and paroxysmal nocturnal hemoglobinuria, PNH, or inherited thrombophilias, like factor V Leiden mutation, protein C, S deficiency, and antithrombin II deficiency. Acquired thrombophilias is one of other causes which include antiphospholipid syndrome and malignancies like hepatocellular carcinoma and adrenal carcinoma. Secondary Chiari syndrome is caused due to an external compression or obstruction. The hepatic veins or inferior vena cava is compressed or invaded externally by tumors like hepatocellular carcinoma, HCC, renal cell carcinoma, or by infections like tuberculosis or any inflammatory conditions affecting vessels like sarcoidosis or vasculitis. Iatrogenic causes include post-surgical thrombosis. The major congenital cause is congenital IVC web. Risk factors for Chiari syndrome include hematological disorders like polycythemia vera, myeloproliferative neoplasms, hypercoagulable states like protein C, S deficiency, and antithrombin III deficiency, oral contraceptive pills, ACPs, and hormonal therapy, pregnancy and postpartum state, chronic inflammatory diseases like inflammatory bowel disease, BEHETS disease, malignancies like hepatocellular carcinoma, renal cell carcinoma, adrenal tumors, lymphoma, etc. Infections like tuberculosis, HIV, aspergillosis, and congenital IVC anomaly. Chiari syndrome occurs due to hepatic venous outflow obstruction, leading to congestion, ischemia, and liver dysfunction. The pathophysiological sequence is as follows. First and foremost, there is obstruction of hepatic venous outflow, caused by thrombosis or external compression affects hepatic veins, inferior vena cava or both. Increased sinusoidal pressure and hepatic congestion. Blood flow from the liver to the heart is impaired. This causes sinusoidal congestion. This sinusoidal congestion leads to hepatocyte hypoxia and necrosis, predominantly in zone 3 or centralobular region. Portal hypertension is caused by increased resistance in the hepatic circulation, which leads to portal venous congestion and development of collateral circulation like esophageal varices, caput medusae. Ischemic injury leads to hepatocyte damage, inflammation, necrosis, and fibrosis. Chronic congestion and hepatocyte death stimulate fibrosis and regenerative nodules, progressing to cirrhosis. Increased hepatic sinusoidal pressure leads to transudation of fluid into the peritoneal cavity, causing ascites. Reduced albumin synthesis worsens fluid retention and peripheral edema. Liver failure in advanced cases is caused by severe hepatocellular injury resulting in liver dysfunction, jaundice, coagulopathy, and encephalopathy.